Hello parents, we want to thank you very much for coming today. We understand that you have young ones down the hallway that you want to be with, so we'll try to make this as brief as we can. My name is Matthew Bell.
I'm Jana. And I'm Ellie.
And we are speech-language pathologists here at the hospital, and we're here to try to answer some questions about dysphagia. So starting off, just a brief overview of what we're going to be doing today. We're going to be discussing pediatric anatomy and physiology of swallowing. We're going to be talking about the prognosis for infants identified with dysphagia, contributions to dysphagia in premature infants, treatment options that are available, and most importantly, we can't say this strongly enough, we are here to support you.
So first, to get started, it's very important to know that the anatomy and swallowing function of your infant and you are very different. So in an infant, you may notice that their chin is low and it's in contact with their rib cage. Also, their neck muscles, head stability, and trunk stability are not fully developed yet. Their jaw, tongue, cheeks, and lips work as a unit, and they're not able to move these structures independently. So, for example, when we take a bite of food, we use the tip of our tongue to propel it backwards, whereas a baby, they don't have that control yet, and it's just one single movement. The tongue is large, and it completely fills the oral cavity, as you can see in the image above. They have sucking pads or fatty tissue pads inside the cheeks, and it provides stability and support in the cheeks to compress the nipple and direct the liquid towards the center of their mouth. And this develops within the last 2 weeks in utero, and it's so, as you probably have noticed, that it's not fully developed in premature babies.
Okay, so a little bit on the physiology of your new baby. Naturally, infants are obligatory nose breathers, and this is because their tongue takes up so much space in their mouth. But as they grow, their structures are going to grow and lengthen and become more adult-like, and this usually occurs by around age 3. Infants have a shared pathway between swallowing, feeding, and respiratory systems. It's a suck, swallow, breathe pattern, which is a coordinated sequence about a rate of 1 second. It consists of bursts of sucking followed by a brief breathing recovery period. And the high accuracy and timing between the breathing and sucking and swallowing is very essential for development of your child. And this can sometimes be a problem with the premature babies. So a full-term infant usually has a suck-swallow cycle of 10 to 30 before a breath occurs. But for premature infants, this usually is only 3 to 5 suck, swallow per breathing cycle, which is kind of a less efficient feeding, and why we're here today to talk to you about some of the things we can do to fix this.
All right, so now we'll talk a little bit about how the normal development of feeding and swallowing. This depends on multiple factors, one of which is central nervous system maturation and overall development, the medical stability or medical health of each child, the postural stability and control, and their overall strength, the timing of food introduction and method of delivery, and the child's early experiences with feeding. You'll notice with some of these earlier ones about medical stability, central nervous system maturation, and postural stability. These are things that a premature child is going to lack, at least for now. But ideally, as they age, these are things that will improve. The timing is something that we can have control over, and we'll go into a bit more detail later on. But the timing of food introduction can be an issue even for children who are typically developing. So, and also their early experiences. Positive ones are going to usually mean a bit more success, and negative ones are going to make them shy away from the feeding process, which can lend to more problems and disorders.
So as an SLP, we work a lot with dysphagia or swallowing problems. And dysphagia is a problem in any phase of the swallow. So it can be in the oral prep stage when you're preparing to take food in, oral transit when you're going to move the food back, and then the pharyngeal phase, and then also the esophageal phase. And so any problem in these stages can lead to aspiration, which is when food or liquid gets into our airway. So some signs of this would be apnea, when they have 15 to 20 seconds when they're not breathing, or a slow heart rate during feeding, decreased saturation level, which is low oxygen levels. And some more overt signs would be coughing, choking, sputtering, gagging, frequent vomiting, color changes. So if you see any bluish around their lips or gray, this is a big red flag. prolonged feeding, so if it's taking over 30 minutes, this can indicate fatigue with infants. If they're not gaining weight, or they're showing signs of failure to thrive. Pneumonia, repeated upper respiratory infections, or a wet and gurgly cry.
Okay, so I'm sure a lot of you here today are wondering, when can my baby be fed normally? So if left untreated, a child with a swallowing disorder can have permanent physical, mental, and or behavioral damage. But we are here to tell you today that with treatment, most children with a feeding disorder do show significant improvements. Treatment is most effective if both the child and parent receive nutritional, psychological, and social training. So it's a great sign that you guys are here today educating yourselves to help your baby. Each child is different in the nature of each individual disorder, so this makes it hard to determine a time frame of when this problem will resolve. But it's a good sign that you guys are here today wanting to help your baby.
All right, so I want to discuss real quick some of the contributions to dysphagia. You see here a lot of big words, a lot of scary words. Parents, some of you might recognize these as they might pertain to your child. The big three categories are diseases and disorders, congenital anomalies, and prematurity and or low birth weight. This is one that is actually a common denominator for everyone here, so I'd like to discuss that. Premature development. This can lead to multiple medical problems and problems with parent-child interactions, because I'm sure there are plenty of children right now who are still in incubation right now. But this is something that can be resolved later on. You can actually get some hands-on time with your children, and also some one-on-one with them. We'll actually get into that a little bit later.
So where do you start now? Some ways to help your child is by following their signals. If they're hungry, feed them promptly when they indicate that they're hungry. Hold the infant close for eye contact. Their visual acuity is not as great as ours, so you want to keep them about 12 inches from you. And also having that eye contact allows for joint attention and just basic communication skills early on. You want to hold your child close and securely, but not restrictively. You want them to be secure where they're not moving around and that their posture is good. Also, holding the nipple at an appropriate angle. This is something that a lot of people don't think about, but you just want to make sure that their body is naturally able to work with gravity. And then monitoring the flow of the liquid. So that's something as an SLP we can help you with, whether we need to thicken it or just to put more holes in the nipple or less, just depending on how fast we want that to flow. And then just talk to your baby and smile, which is a natural thing for parents.
Okay, and us as SLPs, we are here because we have a specialized knowledge of the oral, pharyngeal, and laryngeal anatomy and physiology of your new baby. And we also have a lot of knowledge of the development of your new baby and how they should be feeding and swallowing. And we also are a huge part of the multidisciplinary team for the hospital. So we will definitely be around and be a part of the treatment of your child. And as well, we are here to serve as counselors for you, parents. We can help you with treatment and training of the feeding and bonding with your baby.
So some of the more common treatment options that we want to focus on are making the muscles of the mouth a lot stronger. We also want to increase tongue movement, and we also want to improve sucking and or drinking ability. We usually do this through something called non-nutritive sucking, which involves having your child suck on something that will not actually give them any nutritional value, like a pacifier. This is just training so that they'll get used to the the suck, swallow, breathe reflex. And this, like we just mentioned, this will actually help coordinate that pattern a lot better, make it more efficient, and hopefully decrease breakups in that. We also want to focus on postural changes. As we discussed before, we want to have them at an angle that's appropriate for them, as well as a distance that they can actually see us, we can see them. And that way they also feel a bit more comfortable with us, and it helps to foster good interactions and positive interactions during the feeding and swallowing process. So we've talked a lot about a lot of things. Pediatric anatomy and physiology of swallowing, prognosis for infants identified with dysphagia, contributions to dysphagia in premature infants, treatment options, And I can't reiterate enough. We are here to support you. And that being said, you've had a lot of things thrown at you. What questions do you have for us?